Hello, class. Welcome to Flourish Nursing Academy. I am Tutor Godwin. We will be discussing liver cirrhosis. Definition: cirrhosis is a chronic progressive condition characterized by diffuse hepatic fibrosis and the formation of regenerative nodules that distort the normal hepatic architecture. These structural changes impair hepatic function and venous outflow, commonly resulting in portal hypertension and eventual hepatic decompensation. Causes and risk factors. Etiologies of cirrhosis are diverse. Common causes include chronic viral hepatitis B and C, alcohol-related liver disease, and non-alcoholic fatty liver disease progressing to non-alcoholic steatohepatitis. Less common but clinically significant causes include autoimmune hepatitis, cholestatic diseases such as primary biliary cholangitis and primary sclerosing cholangitis, hereditary metabolic disorders, for example, hemochromatosis, Wilson disease, and alpha-1 antitrypsin deficiency, and drug or toxin-induced liver injury. Risk factors: chronic heavy alcohol consumption, metabolic syndrome, obesity type 2, diabetes mellitus, history of viral hepatitis, intravenous drug use, blood transfusions before effective blood screening, family histories of hereditary liver disorders. Pathophysiology: cirrhosis is the endpoint of sustained hepatic injury. Recurrent hepatocellular injury and inflammation activate hepatic stellate cells, which differentiate into myofibroblasts and deposit extracellular matrix proteins, principally collagen. Progressive fibrosis disrupts sinusoidal architecture and hepatic microcirculation, producing regenerative nodules. Consequences include increased intrahepatic vascular resistance that precipitates portal hypertension, reduced synthetic function manifested by hypoalbuminemia and impaired coagulation factor production, diminished detoxification capacity leading to elevations in circulating toxins such as ammonia and cholestasis with impaired bile excretion. Portal hypertension also causes collateral circulation formation and splenic sequestration of blood elements, contributing to thrombocytopenia and leukopenia. Clinical manifestation. Clinical manifestations vary with disease stage. Compensated cirrhosis may be asymptomatic or produce vague complaints: fatigue, anorexia, weight loss, and right upper quadrant discomfort. Decompensated cirrhosis presents with more specific and potentially life-threatening features, including jaundice, pruritus, ascites, peripheral edema, and manifestations of portal hypertension, such as splenomegaly and variceal hemorrhage. Additional findings may include hepatic encephalopathy, coagulopathy with easy bruising and bleeding, hyperestrogenic signs such as gynecomastia and testicular atrophy, spider angiomas, palmar, erythema, and caput medusae. Specific clinical signs: ascites, progressive abdominal distension, shifted dullness on percussion and fluid wave, variceal bleeding, hematemesis, melena, and hemodynamic instability. Hepatic encephalopathy, altered mental status ranging from subtle confusion to coma, asterixis on exam. Jaundice, scleral icterus, and yellowing of skin due to bilirubin accumulation. Coagulopathy, prolonged bleeding times, elevated INR. Diagnostic investigations. Diagnostic evaluation integrates laboratory studies, imaging, and, when indicated, histologic assessment, laboratory investigations, liver function tests, bilirubin, alkaline phosphatase, gamma-glutamyl transferase, alanine aminotransferase, and aspartate aminotransferase. Note that the AST-ALT ratio may be elevated in alcohol-related disease. Synthetic function serum albumin and prothrombin time international normalized ratio (PTINR), complete blood count, anemia, thrombocytopenia reflecting hypersplenism. Metabolic panel, electrolytes, renal function, hyponatremia may complicate advanced disease. Specific tests as indicated: viral hepatitis serologies, autoimmune markers, ANA, asthma, antimitochondrial antibody, iron studies, ceruloplasmin, and alpha-1 antitrypsin levels. Imaging, abdominal ultrasound with Doppler. First-line modality to assess liver morphology, ascites, and portal vein patency. Can suggest cirrhosis and evaluate for hepatocellular carcinoma surveillance. Transient elastography, fibroscan, or MR elastography, non-invasive assessment of hepatic fibrosis. Computed tomography or magnetic resonance imaging for further structural assessment and lesion characterization. Nursing management. Nursing management emphasizes patient safety, vigilant monitoring for complications, symptom control, and collaboration with the interdisciplinary team. Priorities include prompt identification and stabilization of life-threatening conditions, prevention of further hepatic injury, and patient-centered education. Assessment and monitoring. Frequent neurologic assessments to detect early hepatic encephalopathy, level of consciousness, orientation, attention, and motor signs such as asterixis. Hemodynamic monitoring. Vital signs and assessment for signs of hypovolemia or bleeding. Daily weights, accurate intake and output, and serial abdominal girth measurements to monitor ascites and fluid shifts. Strict monitoring of laboratory values, electrolytes, renal function, liver enzymes, albumin, INR, and complete blood count. Inspection for bleeding and skin integrity. Apply fall precautions for patients with encephalopathy or coagulation abnormalities. Fluid and electrolyte management. Implement sodium restriction and fluid management per provider orders. Monitor response to diuretic therapy. Common diuretics include spironolactone with or without loop diuretics. Nurses must observe electrolyte disturbances, renal impairment, and orthostatic hypotension. Ascites management may require therapeutic paracentesis. Nursing responsibilities include patient preparation, monitoring hemodynamic stability during and after the procedure, and observing the puncture site for bleeding or leakage. Hemorrhage prevention and management. For patients with variceal hemorrhage, prioritizing airway, breathing, and circulation. Anticipate large bore IV access, transfusion support, and emergent interventions. Nursing care includes continuous monitoring, blood product administration per protocol, and supporting endoscopic or interventional procedures. Minimize invasive procedures and enforce bleeding precautions for patients with coagulopathy. Monitor INR and platelet count and collaborate regarding the need for vitamin K or blood component therapy. Hepatic encephalopathy. Implement safety interventions, fall precautions, frequent reorientation, and airway protection when mental status declines. Promote bowel regulation to reduce ammonia production. Administer bowel medications such as lactulose or rifaximin as prescribed, and monitor stool,